Well, I'm going to talk about facts and figures. This is our acknowledgement slide. I want to again say mahalo to Queens Medical Center for both being a partner on the grant, but also helping us secure this wonderful space. And behind the scenes, brilliant AV people that are supporting almost another 60 or 70 people who are not here physically, but are here metaphysically on Zoom. I looked at the theologian for that. He nodded when I was right. Just a client list. You can see we have diverse engagements, but none of our clients have told us what to say or do. Living alone with dementia, facts and figures. Frequently, when we raise that as a topic, I think of the bumblebee. Until very recently, it was believed by aeronautical engineers and others that technically a bumblebee had no business flying, and yet it does. And I think getting our mind around living alone with dementia is a little like getting our mind around the fact that bumblebees fly and perfectly well, even though according to engineers, they shouldn't. According to many people, people couldn't possibly be living alone with dementia, except they are, and in large and growing numbers, especially here in Hawaii. So is it possible? Well, here's the thinking about the numbers. 1 in 5 persons with Alzheimer's disease or related dementia live in a single person household. And single person households living alone, people living alone, is the fastest type of household in a growing type of household in America for the last 2 censuses. Now, this is driven by many, many factors. But when you look at the trend lines, we're already at 1 in 5 persons with Alzheimer's disease or related disorders live in a single person household. Why is this? Well, one of the whys is we now have a greater appreciation for the fact that dementia doesn't happen all at once. The people do not become disabled from Alzheimer's or frontal temporal dementia or from strokes all at once. That in fact, there are phases, there are different things that we can do. This is a public health approach to Alzheimer's disease, where we even start at what can we do about primary risk reduction all the way to safety and quality of care as people are less able to make those decisions for themselves. So part of why are there so many people living alone with Alzheimer's or dementia is because we now understand that dementia is not just what we used to call it senile, the pre-senile dementia. Some of you may be old enough to remember sending people to mental health facilities with a diagnosis of, well, hardening of the arteries or pre-senile dementia. In fact, Alzheimer himself was on the trail of trying to understand why some people showed the signs of dementia, memory loss, confusion, disorientation to time and place, but early. Auguste D., the patient who he wrote up about and did those slides about, by the way, ably assisted by a Black American physician named Solomon Carter Fuller. Look him up. Should be called Fuller's disease. I digress. But when Alzheimer did his original work, he had a patient who was showing signs of senility much, much younger than expected. We've moved out of that language, but in fact, we now really understand that there is a big bandwidth. Dementia is a big bandwidth, which accounts for some people living alone with dementia. If you look at people living alone in the state of Hawaii, we're at 50,000 and growing. And if you believe that 1 in 9 over age 65 have Alzheimer's or some other irreversible dementia, you can do the math. We did the math. We tried to find some hot zones. Is anybody here from any of these places? How about Punch Bowl? That's our neighborhood, folks. 18% of people over age 65 live alone in this neighborhood. Look at Papaaloa, zip code 96780 on the Big Island. Heidi, this is your neighborhood. 29.4% of people over age 65 live alone. These slides, by the way, will be available somehow. I don't remember the magic, but Volcano on the Big Island, Papaaloa, but all of these are zip codes and neighborhoods where greater than 15% of people over age 65 live alone. When I've advised the team at Catholic Charities where to focus, where to find partners, where to find potential persons living alone with dementia, I've suggested that these might be places where any of us could start. Willie Sutton robbed banks because that's where the money was. This is where the people living alone with dementia are likely to be. But these are some shocking numbers. There are some, the worst we've ever seen are 2 zip codes near Reno, Nevada, where we have 35 and 36% of people over age 65 live in a single person household. You know where they are? They're in the resort area near Lake Tahoe. So physically, emotionally, and geographically challenged living alone out there, particularly in winter, which apparently you guys don't have. It's snowing at home in Maryland today, as you saw, Kate. Let's think about all in all, 20% of people who are living in Hawaii live in a single person household. Additional disabilities, we don't think about these often, but sight and hearing problems affect about 20% of people over age 65, and 18% of people in Hawaii are foreign born and may have language challenges. I learned this not only by looking at facts and figures, but I've been tutored well by a wonderful native of the Big Island named Frances Kakagawa. She's a poet. She's a poet, a prophet, a priestess, a king. She's just about everything. And if you don't know her work, and you don't know her work in particular with trying to come up with creative ways to support families with Alzheimer's disease and people living with Alzheimer's disease who have language challenges, see me later and I'll tell you the secret. So what are the other challenges here when we think about facts and figures? Only 40% of people with Alzheimer's or a related disorder get a formal diagnosis. And that's in the best of times. You go rural, this number comes way down. And by the way, you have some rural, even though we're in the middle of a really big city. When you get out, you know that. More sadly, it has still been consistent for 20 years that a third of people who get a formal diagnosis, it is not disclosed. So let me be really unfair and put that another way. So only 40% of women who have breast cancer get a formal diagnosis. How's that make you feel? And of the 40% of those women who get a formal diagnosis, a third of them aren't told. Why is this acceptable for dementia? I don't know. And this is not to say anything about the geriatric teams and others at Queens that are hustling on this, but I don't understand how you could make a formal diagnosis, put it in a medical record, and not disclose it to the person. There's just something fundamentally wrong in the value system that has that happen. So diagnostic headwinds, why isn't there more going on about people living alone with dementia? A minority of people get the diagnosis in a formal way, and of those who get a formal diagnosis, many are not told. I would say 30% is many. So live alones, it's driven by demographics. Why are there so many? Why is it growing? Spouses and partners die. Younger persons in 55 and older communities get older. I have a friend who has a wonderful business helping these 55 and older active aging communities figure out what they're going to do when those 55 and olders are 75 and older. I think it's driven by demographics because it's a function of wealth and how we live. And on the mainland, most of us live not in a multi-generational household on the mainland. Maybe different in the islands. There is a divorce rate of at least 40% of boomers. Thanks for changing everything we've been a part of, from elementary school, where I went to something called double sessions because you couldn't build and fill the schools with staff fast enough. So I went to 3 hours a day of second grade, and I have no idea what I missed because they brought a second shift in for another 3-hour day. But a 40% boomer divorce rate. There are increasingly people who never married by choice. And a sub-community that our friend Dr. Jason Flatt from the University of Nevada, Las Vegas, by the way, Las Vegas, otherwise known as the ninth island. Somebody told me that last week when I was there. Made me laugh, and you're laughing, so it must be true. But the LGBTQTA plus community are likely to be more affected as more likely to be live-alones with dementia as they age. I think there are also a population of possibly marginalized persons who are living alone with dementia. People with lifelong mental illness, likely many male veterans, although we're getting close to parity in the Veterans Administration with the growing number of women who have served, and former prisoners. All of this demographic trends, former prisoners who've been released, I should say, all of these are driving live-alones with dementia. This is the classic elephant, you know, grab hold of it wherever you may, and you may think it's a tree, you may think it's a snake, you may think it's a fan. It's many different things, and I think that's what we're talking about. When I think about our work in the last 4 years focused on live-alones, I have 5 categories. This is not science, this is opinion, but there are 5 categories of people living alone with dementia. There are folks that are undiagnosed, who clearly are living with cognitive impairment that is damaging enough that it changes how they live their lives. That's kind of the bottom line here. But they don't have a diagnosis. They may not seek a diagnosis, or they may not have a diagnosis disclosed. There's another group that are struggling to live alone. And this is probably the group where Catholic Charities Initiative will probably focus a lot of its attention. There is a group who are manifesting their underlying dementia in behaviors that sometimes are not misunderstood, that are misunderstood and possibly not treated well. There is a group, and you saw some of them with care maps, you saw Mary and Benji. There is a group that are coping and living well alone with dementia. But remember what Kate said about Mary. Doing that care map gave us the opportunity to ask Mary, this is the now, what about later? Because you have a progressive disease. And last, there is a group of people living alone with dementia who are abjectly unbefriended. They may be street people, they may be the rough equivalent of street people. They live rough lives. We see them in homeless shelters. We see them in other distress. Most of the live alone programs in Alzheimer's that we're aware of have tried as their starting point to work with the group of people that are abjectly unbefriended. And they do it as a single agency and they fail, which is why we've collected many people both here and on Zoom to make this a more of a community dementia capability project than a Catholic Charities alone dementia capability project. I will also tell you that probably because, you know, yes, I'm a starry-eyed Disney guy. I have daughters. Oh, the princesses. Jeez. You know, but I know Ohana is real. I know the sense of commitment between and among the generations. I've been all over the country. I've been also on site in 40 other countries doing dementia work. I will tell you, everybody says they're unique, but Hawaii and Alaska are unique. And you are unique, and there's still this spiritual connection that people feel between each other. It may be cultural, it may be spiritual. So many people who are living alone with dementia, ironically, that we may be trying to reach with a program of service, don't think they live alone. Oh, I don't live alone. My neighbor looks in on me. I don't live alone. My son makes sure I get to church. And don't call him my caregiver because I'll smack you. I mean, if you met that woman, you've met that woman, right? So just keep in mind that culture is a lens through which all of us filter our experiences. And when we say living alone in Hawaii with dementia, many people may not think that they live alone because they live with a sense of and with real community. They have real people on their care map. So what are the risks of people living alone? People have distress managing their cognitive illness. They have compromised health. You heard the good doctor talk about the lady with the brittle diabetic with the brittle brain failing and going back to the emergency room over and over again. Do you think we could get Queens to put a question on their intake at the emergency department? Do you live alone? That might help sort out some of the folks that we need to know, because it's not, people don't go to the emergency room for a treatment, acute treatment of their dementia. They go to 75% of people with dementia have at least one other chronic disease. They go to the emergency room because their thinking problems are such that that other disease gets out of control. Other risks for people living alone with dementia is that they are absolutely more at risk of fraud because they have poor judgment, depression and anxiety, and they really have a hard time navigating complex issues like hospitalization. I think societal attitudes, and this is just not my work, Elena Portocolone, who is from the University of California, University of California, San Francisco, says that societal attitudes about what it means to be a person with dementia can directly be a precariousness for people living alone with dementia, because we assume away their rights to self-determination. Generally, more people living alone with dementia have low socioeconomic status and poverty. So the risks are expressed simply, what's the vernacular? I am afraid thinking problems are taking over my life. I have diabetes and sometimes I make mistakes with my insulin. I don't want to lose my nest egg, but I want to trust someone, and so on. So these are all important things to think about. So who's living well alone with dementia? Care mappers, whether they use that tool or not, people actually take the time to map out their network of relationships and think about it. And those who build or have been blessed to have the intention to build community. In my world, for 1,000 years, my wife would tell you that the word community in the Splaine household is a verb. It's not a noun. Community is something you live and work at. People living alone with dementia who are doing well have their basic human needs met. We have a client in Las Vegas that does care transitions from hospital to home. They've had over 3,000 cases, 75% of which were people living with dementia. And of the people living with dementia, a full third were living alone before they went to the hospital and went home to live alone. No, went home to live alone with dementia with support. Most of the time to an empty fridge. You need to think about basic human needs if you're going to do live alone stuff. And it's fill the fridge one time with a respite coach, but please also think about bring a SNAP application with you or Meals on Wheels. But people who are living alone well with dementia have their basic human needs met. And there are all kinds of new creative shared living arrangements emerging. There are shared housing resources on and offline where people are finding ways. This started many years ago at Boston University, where people would trade a room in the attic to a BU kid for in exchange for taking out the trash and being muscle if somebody tried to muscle in on the old ladies and take something from their property. At least that's the way I heard the story told. But there are lots of shared living and creative shared living arrangements. Heck, my wife says we're going to all go back. We've stayed in touch with all the kids that were kids that we lived with when we were in college, and maybe we just start that community up again. The Hawaii, of course, has a terrific state strategic plan on Alzheimer's and related dementias, as well as the Native Hawaiian strategic plan. They're pretty quiet about live-alones. So this is, with a 2035 end date on those plans, this is sneaking up on you. These are some of our important references, and they will be in the slide deck. I particularly point out the work of Elena Portocolone, but we are in touch with all the fundamental researchers like Dr. Joe Gogler. Kate's on teams. We're all in touch with all the people that are doing research into this growing and emerging area. And there is our contact information. So we have a minute for questions. I'm looking at my 11:18. I think we're glad to answer questions. And there any coming in over the chat? Oh, that was jazz hands. I don't know what that meant. I don't speak sign except a couple of them, like this one. Everybody know what this one is? Yeah. If you don't, you can guess. Questions, comments? Well, many years ago, when Kate and I both worked at the Alzheimer's Association, we went to Texas, and I think it's time to bring Kate back up. We went to Texas and did a very difficult meeting with a group of volunteers from all over Texas about their work in public policy. When we got back to the office the following Tuesday, my boss had a note from one of the Texans. You know, Texans are really just, they love being ornery. And they sent our boss a note and said, "Thanks for sending us Beauty and the Beast. Next time, just send Beauty." So with that, let's bring Kate back. All right. And there she is. Thank you.
Thanks, Mike. I do tell my children that not everybody thinks I'm beastly. I have a freshman in high school. She likes Uncle Mike and Aunt Sandy a lot more than Mom right now. Tell me if you can relate. So I hope that as you're getting to know the team that I work on with Mike, you understand that in essence, we are storytellers. We are really bringing the lives of persons with dementia and their caregivers from all walks of life to you. And one of the things that I love to share are how other organizations and other professionals are trying to identify and meet the needs of persons living alone with dementia. I like to one up Mike as well. He did not share this with you, but as a going on the 5-0, I have gone back to school to become a scientist, and I love data. So I'm going to share a few more facts and figures with you that I think are interesting in terms of who are people living alone with cognitive impairment. So I'm going to use the term cognitive impairment for a moment. This is not people necessarily who are just diagnosed with dementia. So that, as Mike said, where your cognitive impairment and other impairments are severe enough that it affects your everyday life. The numbers that I'm giving to you are people who also include those who have mild cognitive impairment, not subjective cognitive impairment where you just think that something's up, but where you've actually had a form of diagnosis. So amongst people either at that mild cognitive impairment stage or who have formal dementia, the way that you read this is not across the path. So it's not 66 plus 49 here. we're going to go down the columns. So among people who live alone, 66% of them are women. And as Mike mentioned, a big reason that that happens is just demographic trends. Women tend to live longer, and so we're living longer into greater risk for cognitive impairment and dementia. So 66% are women. The average age of people who are living alone is 76. So let's just think about that for a second here. 76 is the average, which means like the middle. That means that a full 50% of people are over the age of 76, right? So these are older people with cognitive impairment living alone as much as they're younger people with cognitive impairment living alone. When we think about what resources that they have, only 55%, these are US national numbers, by the way, only 55% own their own home compared to people who are living with others, where 73% of those living with others own their home. Now, those may be people who are living with their adult children and they are living in the elder's home. I think it's pretty stunning. These are numbers from a long ago and far away. The total net assets of or liquid wealth of a person living alone with cognitive impairment compared to the wealth of people who are living with others is pretty startling. So if you can envision with inflation and the challenges that we have nowadays, these numbers still stand, but they're a little bit more of a gap. Mike talked about why are people living alone? Amongst those who are living alone, 61% of them are widowed. Or thank you again, baby boomers, it's okay to be divorced. We always get this question about, well, probably most of those people were never married, but in fact, among people living alone, only 11% were never married. And this 2% of people who remain married but are living alone are also part of some shifts that are happening culturally, where your spouse may be living away from you, or as I'll show in a few slides, there may be other circumstances for which they don't live with you. In the medical field, and in social services, we often think, well, if an elder is living alone, they are probably covered by Medicaid and they're getting services. But in fact, nationwide, only 20% of older adults living alone with cognitive impairment report being covered by Medicaid. So these are folks that may be eligible for in-home services and other special services, but at 20% of the overall total population, that's not a lot of people who have access to those particular services. I still love stats. I love stats. Can I say that again? I love statistics. I'm getting my PhD in statistics, folks. Like, I didn't take math for 25 years. I got to do it all over again. I now know how people get these numbers. I'm going to hire people half my age and twice as smart as me to do those numbers in the future, but at least I know what I'm hiring them to do. Again, going back to what do our numbers look like, there are 15.2 million people in the United States over the age of 65 living alone. So forget percentages, we'll just talk about numbers there. That's a heck of a lot of people living in a higher age of risk for cognitive impairment. And what we know, those 15.2 million people living alone is a risk factor for dementia. And again, amongst those who are living alone with cognitive impairment, it's high numbers. As a social worker, when I hadn't known people who were living alone with dementia, if you had asked me to kind of describe your typical person living alone with dementia, this is a picture that would have come to my mind. And perhaps it's a picture that was already in your mind when we started today's meeting. These are the group that Mike said are the unbefriended. They are potentially living in squalor and self-neglect. And this is where oftentimes the decision makers, the politicians, and people who are in levels of authority think about people who have cognitive impairment who are living alone. Our friends in adult protective services often find these individuals in times of crisis. But in reality, communities have to be able to identify and serve people who are living alone at all stages in in the heterogeneity, the diversity that they live their lives. Like Diana, who was skydiving and lives a vibrant life. I love to share beautiful people who've come into my life who are living alone with dementia. It's with deep respect and remembrance that I share with you the story of my friend Pat, who I met in 2018 when she was a person living alone in St. Louis, Missouri with dementia. She was still driving her car. She was still volunteering both in her church community and with the Sisters of the Delta Sisterhood, for whom she was a national figure. She lived alone until her death in February of 2024, far into the stretches of dementia where others would say she couldn't live alone. Indeed, she had support of her daughters who lived in her hometown, but she fiercely and independently wanted to remain at home alone where she felt most comfortable. I'd echo some of the words that Mike said around why are people living at home alone, and just give a couple of more thoughts. Personal choice, in that, like Pat, they just preferred to live alone. For those of us who live long enough and are blessed to have many lives in one, we may be outliving all of our family and friends, so they're not around anymore, and we just didn't develop new friendships. I I am very close to those who others have chosen to discontinue contact with. I had a wonderful aunt who, no matter how many times I told her I loved her, she would just go, humph. And she cut off relations with her only daughter who had a cognitive disability because she married another person with cognitive disabilities. The only blood relative that she had who was close to her was cut off. Others of us, no matter how many times we tried to get her assistance, she refused. She fired no less than 16 personal care aides. Why any agency continued to keep her on, we're all baffled. But there are those among us for whom their family and friends have just had it, and they choose to discontinue contact with them. And then there are these folks who, as I said, may be married still, but temporarily their caregiver is out of the picture. Maybe their caregiver was hospitalized for a cardiac event and have to go to rehab. And they're in the unexpected situation where then maybe that temporary rehab stay turns into a longer term stay where their caregiver will now be in long term care for the rest of their lives. They're still married, they would like to live together, but now that person is living alone. One of the biggest challenges that we have because of this diversity of people living alone is what we know it's a problem, we know they're out there, but how do we find them? How do we connect with them? Especially if they're not coming knocking on our door asking for assistance or self-identifying as someone who lives alone because they don't want to be found out or placed someplace, right? So there are some programs in the U.S. that are active. Many of them are through the first responders networks. So these are two examples that I have to share with you this morning. The first one is on the left-hand side, the Senior Watch program. This is a program that's been in existence in Lake County, Florida, which has one of the highest percentages of people living with cognitive impairment in the community in the country. This is a registry, so somebody has to sign up to have the police department have where they have volunteers who regularly, daily check on persons who are living alone to ask them what their needs are. Do they need food? Do they need a ride to the doctor's office? Do they just need a friendly person to talk to? But the caveat here again is that they have to register. So they have to be known or they have to be identified for somebody else. There's a specific group in the states called the International Association of Chiefs of Police who have created programs that are replicable in local communities that are these volunteer registry programs, and they have a deep level of training available for first responders. So this is a program that you don't have to recreate the wheel if it doesn't exist in your locality. They train the law enforcement on how not just to communicate with someone with dementia, but also where are the places that they would likely to go missing. One of the challenges that we have in working with people who live alone is that if you live alone, who knows you went missing? So these types of programs that communicate with people who are living alone on a daily basis or more frequently help us in these instances where people may not know that they're wandering within the community, and these emergency responders are available and know how best to search for them. Another program that I want to share with you has been around since the 1970s. It's not that new. It's called the gatekeeper model. Some of you actually may be familiar with it. It was developed by a social worker named Ray Rashko, who's still with us today. Uh, and he identifies, just as I did, those who most need help are probably the least likely to ask for it. Either they don't know the help exists or they can't recognize the challenges that they're currently facing. So, this is a model of identifying people who are living alone in the community, who are at particularly high risk of dementia or potentially already have dementia. And the way that they are identifying people, as you can see on the screen, is through discrete surveillance. So, basically they train people who are in the neighborhood. And I'm sorry, I am born before the 1986 time, but I did watch and was educated to speak both English and Spanish using Sesame Street. So these are who are the people in your neighborhood, the people that you meet when you're walking down the street each day. These are your mailmen, the people who are at the grocery store, people who are at your banks. They're not the care network, but there are others who see you on a daily basis who are trained to start to recognize that maybe you're having some challenges. And what they then do is refer you to the social services network so that somebody goes and checks on you and tries to establish that relationship to help to refer you to services that you might need. So, this model, again, much like the International Chiefs of Police, this is an existing training that teaches your average person that you come into contact with, like your mailman, what signs to look for. Or maybe I shouldn't say mailman anymore because not everybody gets them, but maybe like your Uber driver or your person who drops off your packages from Amazon, however you want to think about it. But they teach them to look for things that we in the care field would know to look for. They appear as if somebody is unkempt, they're unwashed, they're having financial problems, their home is becoming more dilapidated. I don't think that the shoveled walkways have anything to do with the state of Hawaii, but if there was something that is more relevant, that they're not keeping up their gardens, for example, and that was something they had pride in before, that if those changes are happening, they see those as signs of possible cognitive impairment. And the way that the gatekeeper is this person who's in the community with their eyes out looking at their neighbors. They don't walk up to the person and say, let me refer you to social services. No. The discreet way that it's done is that those gatekeepers have been trained to make a referral saying, this is the person's name, this is where they live. And then the social service organization like Catholic Charities and their social work staff and others would come in to try to establish that relationship. And what does that relationship look like? Well, it looks like getting into their home. Not like it is as APS, where maybe I have to go into a crisis, but much more of a proactive way to look at what kind of a service that they might need based on their home environment. So this is an example that's a dementia specific gatekeeper model. This is out of Orange County, California, from a group called Alzheimer's Orange County, where they have specifically trained people to be these community gatekeepers to support people with dementia. So again, these services are out there, the trainings are out there, much like the grant that Catholic Charities has. Alzheimer's Orange County also received a grant from the US federal government, which means just like the care maps, this is in the public domain. So anything that they've created is something that you could take, rebrand, make it your own, but using this as a model so that you don't have to recreate. So once we find people in the community, which sometimes it's difficult to do, how do we know that we're meeting their needs? So as Mike said, I do do research on individuals who are living alone with cognitive impairment. And one of the activities that my team is doing is to take a look at all of these grants, similar to Catholic Charities, who were required by their grantor, you and I, the people who pay their taxes. Yeah, that's us. We told them what to do. Okay, the federal agency that they received funds for really told them what to do. But I like to think that my federal tax dollars are going towards serving people living alone with cognitive impairment. I digress. We're studying what happened in these grants. What types of unmet needs did the people like Catholic Charities find in the community amongst people who are living alone? So on the side where it says service provided, that's what the social service agencies did for people. But I think more importantly is to look at these are the most common unmet needs of persons living alone in the community with dementia. First, and these are in ranked order according to these other organizations. So home safety, if there are any occupational therapists in the room or online, this is a huge portion of the work that I know you do, but home safety is definitely a concern for folks. It's not just about picking up the rugs and turning the lights on. There are many other things where we find people in precarious situations where it's actually not safe to be at home without some accommodations. So home safety is amongst the top, or is the top issue that people have found. Poor health conditions and challenges with medication management, which typically ends people up in the hospital, again, not because of their dementia, but because they've taken one too many of their heart medications and they've failed to thrive. Nutrition and hydration. They don't remember if they ate, or they're overeating. They only want to eat sweets, right? That's what tastes good, especially as your palate changes throughout your cognitive process. People who are having challenges with self-care, so they haven't bathed. Transportation, I can't get anymore to the doctor's office, so I can't take care of myself, or I can't get to places where the people that I care about or support me are living. That's an unmet need in transportation. They also don't know if they are eligible or if they can access government-funded programs like Medicaid or like the SNAP program or meals programs. People with cognitive impairment don't even know what they're eligible for. And then finally, like I was sharing with the story about Mary, is that they have not done advanced planning in their lives. So they don't have the documentation necessary to move forward. And then if they do have support from their friends or their family, another challenge that they face or an unmet need that they have is what degree of support do they need versus the degree of support that they actually have. So the types of support that they might have are like I have in my situation, where my family lives directly next door, where the person with cognitive impairment receives daily support, sometimes hourly support of us walking back and forth to make sure that they're okay, and that we're visiting them and we're monitoring what's going on in their life. Other people may not be living close to their relatives and not be having somebody check in on them on a regular basis. And they may just receive check-in calls from their long distance relatives. I've met a gentleman who is actually a police officer whose mother lived quite a distance from him. He was living, as Mike said, we got a lot of clients in Las Vegas, and his mom was living in Chicago. And he was still frequently supporting his mother, even though he was a long distance caregiver, because every day when he woke up, his mom was living alone in her apartment. When he woke up, he would call her and ask her to use this little technology here, her phone, and asked her to turn her phone camera on. And he was able to monitor what was going on in her living situation, to the point where he'd ask her to open up her refrigerator and show him what was inside, so he'd know if he had to have food delivered to her or have a neighbor check in on her. So check-in calls may be actually more support than you or I would think. And that distance caregiver is providing monitoring. And then, as Mike noted before, and I've said, we've got these folks who have no known supports whatsoever. Nobody's coming to their side. We already talked about ways that, okay, so now you've met them, you know them, you kind of have a sense of what the needs might be. We already talked about determining whether there's a support system, and you now know how much I despise the checklists, even though I was trained on them as a social worker, and how much I love the care maps. But one of the challenges that we face when thinking about these needs and who's going to help to fulfill the needs, especially of people who are living alone, if we identify somebody, we hit this. I am never sure when to step in, especially when somebody's living at home alone. I don't want to rob her of her independence. So even if they have support on the outside, often family members are hesitant because they haven't been asked. So I'm going to bring you some more tools. This is a tool that was developed from the University of Iowa, and it was a tool for rural families who were asking their nurses, their home care nurses, well, at what point do we need to step in? When is it bad enough that they're going to need for us to pay someone who's a home care aide to come in to help them? So this tool was developed to help families to understand what bad enough looks like, and I think that it's helpful for those of us who might not understand what that means. So this is one tool that we use, and it moves from the level of needing immediate help to let's just keep an eye on them. So immediate help would be something that if you're in the helping professions, you would know this, that if somebody has lost more than 10% of their body weight in the last 6 months. So somebody would have to know what they looked like. Does the person have continuous paranoia hallucinations? Maybe they're actually having a delirium experience, and it's not necessarily just their dementia that's causing their challenges. They've threatened their neighbors with weapons or violence. These are things that are immediate help. Now is the time to step in. Versus on the other end of the spectrum, that maybe they just sit all day watching television, right? Is that harmful for them, or is that how they're expressing and living their best life right now? Not everybody has to go to the senior center or to the community center and be fully active and present. Sometimes it's okay to have that change in lifestyle. We're keeping an eye on them, but let's maybe some other help would be necessary, but let's let them be for now. So I like this tool because it really helps for having a conversation about when is support needed, when might it not be safe for someone to live alone in their home. This is a similar tool called the crisis to thriving scale, which was also developed in a rural area. Love rural communities. This is created by the Southern Maine Area Agency on Aging, and similar to the previous slide where we talk about at what point do we step in. This particular tool was developed to help people who are in crisis move to or be supported to be thriving in their life. So this is called the Crisis to Thrive scale. And these are often on intake forms that we participate or utilize in our own lives as service providers. We might look at their nutrition status. So if somebody isn't able to cook or prepare food for themselves, then they are in crisis. If you look at the next part over where it talks about vulnerable, they no longer have the ability to use the microwave or prepare their food, and they don't have help, or they are only able to use a microwave to cook. Is that a crisis? I'm not sure. This scale says probably not. But if they have a variety of vulnerabilities, then it's a time to step in. So I think just looking at the ways in which people might not be thriving, and it's not just that they're alone or lonely, right? We're looking specifically at what are their needs in a more holistic manner. Another tool that was developed through one of these grants is called the Live Alone Safety Net Algorithm. It's a lot of words, but this is what we call a decision tree. So people in the medical professions are more likely to have come in contact with something called a decision tree, but it's like choose your own adventure. If this, then what, right? So this starts off with it's a social service network tool where mainly for social workers or similar professions, if I come in contact with somebody who's living alone and exhibits some symptoms of memory loss, what do I do? And what resources do I have? So the algorithm says, well, if they're in immediate danger, if they're at that crisis stage, we're going to ask others who are better at crisis management and have resources for crisis management, like Adult Protective Services, come and step in. But if not, we're going to, in this case, they refer them to their Live Alone staff and to do a simple assessment. This also helps us to start asking questions about whether or not the person who's living alone actually has a diagnosis of dementia, or others think they might have dementia. And this particular decision tree says, well, why don't we try, if we come in contact with this person, to screen them using a really quick screening tool for cognitive impairment. And this social service agency uses two different ones, the mini-cog and the AD8. So those are two types of screening tools for cognitive impairment. And if they screen in a particular range, then that service agency says, well, why don't I refer you to a medical professional who may be in your healthcare network so that you can be assessed for potential dementia. And if they don't score in that range, then that organization provides them with some resources for brain health and risk reduction, and gives them other information about cognitive impairment that they may need in the future. But as this goes down in, well, if this, then that, and you're kind of going along this algorithm, at the end of the day, it says, well, what types of programs and services should I provide to this client? What needs have they said that they have to us? So this is one side. This is like a two-sided sheet of paper. One side, it gives you this decision tree, and on the other side it says, okay, what does my organization or what does my community have in existence today, not in this kind of dreamland, but what do we have today that we can refer people with cognitive impairment who are living alone to? So this is, I think, a really nice list in categories of the types of services that people who are living alone may need access to, and they need help accessing it, not just a little piece of paper that says call this number. Often they need our assistance to make that telephone call. So it's much more of a warm handoff than it is sending somebody off with a checklist of things to do. All of these referral sources that you see in front of you are places where they're capable of assisting people who are living alone with cognitive impairment. But you've seen, I know, all of these services before. This is things like, are you eligible for veteran services benefits that might provide you with some additional services within your home that a non-veteran doesn't have access to? Do you have challenges with medication management? And do we have resources in our local community through our pharmacists or through other services that can help that individual maintain and manage their medication for their non-cognitive impairment challenges? So I think this, again, it's a useful tool also in a format where you could copy this for your own organization by contacting the developers of this tool. So this is not in the public domain, but it is accessible for organizations to rebrand as their own and change. And then for those of you who are in the medical profession, as I used to be, we know this. Often the needs of our patients with dementia who live alone are less about their medical conditions and much more about the ways that they might be connected to their community as a way to avoid further decline on both physical and cognitive sides. And what are those services that we're going to refer them to? So I'm going to share with you now some of the most frequent types of services and some direct examples of how other not-for-profit organizations similar to Catholic Charities are providing, what types of services they're actually providing to people living alone. The most frequent type of service provided by not-for-profit organizations who are very much focused on persons who are living alone with cognitive impairment. This is not the all populations that they might serve, but I'm sharing with you what are the exact services that they provide that are dementia specific and live alone specific. So it won't come as a surprise to anybody in the room that care coordination is amongst the most frequently provided service to people who are living alone. I've actually walked you through some types of the care coordination services. They're identifying unmet needs. Most care coordination programs out there for persons who are living alone with dementia are doing that in-home visit because they want to see what the holistic health is of that individual in the environment where they're most often at. They work with the person with dementia to create a collaborative dementia care plan that gets updated frequently, sometimes every month if their life is changing that rapidly. But another wonderful thing about care coordination programs is that they are in regular contact with the person with cognitive impairment, and people in their lives for whom they have the ability to contact with, that they have consent of the person with cognitive impairment to share what their life situation might be from their care coordinator. What I think is unique, again, about people who are living alone with cognitive impairment and the care coordination that's provided is that the people providing care coordination spend a lot of time coaching them through this contingency planning for the future. Remember, Mary didn't have an idea of who she was going to call or who's going to help make decisions when she could no longer make decisions on her own. So a lot of time is spent in care coordination with the contingency plannings for their future decline. It doesn't always have to be healthcare. It can also be, where do you move next, right? Helping to coordinate their lives. Because I love social workers, I just wanted to highlight that there's actual research around care coordination for people who live alone. And this is a research project done by a Master of Social Work intern. So call out to all the students out there. This is a field ripe for more research, but specifically around care coordination, I wanted to share that there are resources out there if you're trying to make the case for these types of services. Mike mentioned that another one of our clients does this hospital to home care transitions for people with cognitive impairment, and they have a program that they would love to share farther around the country to do more replication of this program, where of the people who are living alone with dementia who were in their program, only 1% of people with cognitive impairment who are living alone in the community went back to the hospital after their hospitalization for the same problem. So these are people who are frequent flyers, often they're called, people who keep returning to the hospital, but they have been able to keep them out through their care coordination service. Another unique program that was developed by the Southern Maine Area Agency on Aging, which is the same folks who did the Crisis to Thriving scale. They've really spent a lot of time looking at this live alone population and the challenges that they face. As many communities have, they have a home delivered meals program. In the wintertime, because it does get wintry there, in the wintertime, they deliver home delivered meals, but they deliver them in group frozen. So that also could be happening in your community, but they'll provide your whole week's meals frozen. And they recognize that there are many people with cognitive impairment who can no longer heat up their meal. They don't have the processing capability. They may no longer understand how to use the microwave, for which most of these meals are. So what they have is a cadre of volunteers who go in as the warming crew, and they go into the home at the end of the day. They heat the meal if that's the service that the person needs, but they also sit there and provide socialization, because we know through other studies that if people are in a social situation, they're more apt to eat, or they could be modeled that we're going to take a bite now. So it helps people to get that nutrition and hydration that they may not get on their own. They also are trained to make sure that they're looking to see if other meals are left or if there's something else unusual going on in the home. Another unique service that was delivered by a group called Home Care Partners out of where I live in Washington, D.C., was called Cluster Care. And it's where they hired home care aides to be responsible for adults living in senior high rise, so low income senior high rise. And the purpose of this program was to hire home care aides to get people who were living alone in their apartments to go to adult day services. So this is a metropolitan area that had the availability and spaces for people in adult day, but people who are living alone, specifically with cognitive impairment, are not leaving their home without assistance. So these home care aides came in the morning. They were responsible again for 4 residents. They came in the morning, got them up, got them breakfast, got them dressed, and then took them down to a van that took them to adult day program, which then provided them with socialization, nutrition, and cognitive stimulation during the day. And in the evening, often a different home care worker would bring them up the stairs after they got off their bus, back into their apartment, got them their evening meal, and ready for bed. So essentially they were de facto caregivers for that, not de facto, they were paid caregivers, but allowed that individual to leave their home, get the services that they needed, and often medical services were included in that. Another program that's been around for a long time are friendly visitor programs. This is a specific example for the LGBTQ plus groups out of New York City. They've had a friendly visitor program for about 30 years, and it matches a younger TIA plus person with an elder. And, it's to share time with that individual, and it's to share socialization. They don't do any medical or any kind of a physical care for them. Similarly, there's a group out of Florida who called Alzheimer's Community Care, who has a number of services for persons living alone with dementia that take a tech-based approach to the same type of a program. They have a Care Buddy program where a former caregiver of a person with dementia who has lost their loved one volunteers for this program to call a person living alone with dementia for at least one time per week, often more frequently than that because they become friends. But again, it's to provide them with support and connection within their own home. We saw during COVID that a number of providers are now going online and are able to provide telehealth therapy and counseling. And we think this is a great option for persons who are living alone with cognitive impairment. It helps them work on accepting their diagnosis and trying to work through some of the questions that they have about their life in general. We're hopeful that Medicare and Medicaid will continue to reimburse telehealth for that, and some of our private insurances as well. Another program that I think is pretty unique for persons who are living in the early stages of dementia. This program is called Cognitive Stimulation Therapy, and it's an online group intervention. This is an evidence-based intervention. It's not targeted specifically at persons who live alone with cognitive impairment. It's for anybody with cognitive impairment. It's a group session that is unique in that it's designed actually by the people who are in the group. So people who are living alone in their homes can socialize with others without leaving their homes. So transportation is not an issue, but this is a program that pushes people to not just think about, well, how's the weather? What's the television show that you just watched? They do things like assess a picture or a painting by Cezanne and ask, what emotion does this emote in you? Where does this take you in memories that you have in your life? So it stimulates their cognitive abilities a little bit deeper than just having a friendly conversation. I'd be remiss if I didn't pat Mike and I on our own backs. Like, that's allowable. A service that we provide through many of the grants that are funded by the Administration for Community Living is an online private Facebook group called Living Alone and Connected. This is a Facebook group for people, only those who have a known cognitive impairment, who are living alone in the community. And people are asked upfront whether or not they have a diagnosis of dementia or if they have a suspected cognitive impairment, and you're not allowed into the group unless you honestly answer positively for that. And what we do within this group is that we have regular events. So it might be a Facebook Live event, and the issues that we discuss and the activities that we do are driven by the community itself. So the community members who are living alone with cognitive impairment help to define what services they want, what issues that they do want to discuss. And we do fun things. So we do online polls frequently. So this one just asks, how do you find out about community and social events that you attend? And so our participants in the Facebook group, this is not live. This is not in real time. This is giving them the space to answer the questions when they've had time to process it. And it gives them an opportunity to have a little bit more time than a live session would. And then we take the information that they provide in polls and then again use that in our work with them. We did find that when we created this Facebook group, that many people who did not have cognitive impairment wanted to join. And we, of course, as I said, have it excluded. We exclude everybody except those with cognitive impairment. It is a moderated group, but we want it to be for, by, and about persons living alone with cognitive impairment. So what we have done is we've created a secondary group for those who are supporting people living alone with cognitive impairment. So it's called Support PLOD, which means people living alone with dementia. And we welcome anybody who's in the room or on the Zoom today to join us. We just similar to the group that is for persons living alone with dementia, we also provide resources and have engagement opportunities for people who are supporting those who are living alone with cognitive impairment. While I take another sip of water, this is the QR code if you're interested in stalking that page or joining that group. If you are living with someone with cognitive impairment, or excuse me, if you know somebody who's living alone with cognitive impairment, the other group is for them. This is for those of us who are really looking to support persons living alone with dementia. So as I wrap up, I wanted to make sure that we went back to the beginning of the conversation about why we're all here, and that is to help people with cognitive impairment, with dementia, who live alone, live their best lives. The person that you see on the screen in front of you, his name is Mark Archibald. He was the very first person in the United States to privately pay for Aduhelm. He's a person who lives alone, whose family does not necessarily agree with the decisions that he's made about his own care, but he became the first person in the United States to receive that therapy of his own volition using his own private dollars. You can check him out and listen to his talk about what it's like to be that patient, to be him living alone with cognitive impairment. But I just wanted to continue to put the faces and the stories of these people in front of all of us so that we keep in mind, again, the diversity of and the autonomy that people who are living alone with cognitive impairment exist in our world today. Just kind of summarize some of the things that I hope to bring to you, besides the facts and figures that I tried to outdo Mike with his facts and figures. First of all, even though I showed you some evidence-based interventions, there are no evidence-based interventions specifically for persons living alone with cognitive impairment in the United States today. I've shared with you some of the promising programs and practices that we're aware of and how they are similar or different. But what the Catholic charities and other organizations that have these federal grants are able to do right now are to test and share innovative practices so we can find out what works and what doesn't work. What can we do differently to support people living alone at home with cognitive impairment as long as possible? And that's really why we're here today, is to think about how can we do this in our communities? How can we pave the way for these folks and the people that will follow them in the future to live the quality of life that we would want to have?